All right, all right, all right. So today we're going over the slump test. So it's a two tails, one test. Try to come up with a better title for that. Something more having to do with, city of two tails, but that didn't happen. So the first theory, the slump test we're going to go over, is the one mostly practiced and accepted by the medical community at this point, which is more of like a neural container type issue. So the neural container meaning the spinal cord and the dura being able to travel from our noggin all the way down our back into our legs. Okay. And the other theory that I'm going to add in as well is the theory of having decreased respiratory movement variability. So I'm going to give a little description, maybe debate myself a little bit as I go through this. So both of them can suggest a similar type of treatment and an education intervention going forward with our clients. Okay, so let's get into it. So the medical community interpretation at this point being that neurocontainer type issue is that there'd be some sort of disc bulge or something essentially kind of pushing into the cord, so it has decreased ability to stretch and floss through the openings and the passages it needs to get to in order to get down to our legs. So if someone is lacking the ability for the spinal cord to move through, what we'll see is an early and abrupt, with possible pain, end of the motion as we go to lift their foot to complete the slump test. What we should see is a decrease in symptoms as they go to move into more ankle plantar flexion if they're in a leg extended position, or they should get less symptoms when they go from cervical flexion to cervical extension. So the ideas the most common understood interpretation of this test is that there's a disc bulge and the nerves going down through the legs can't move very well. Another interpretation, still following that kind of medical community, there's a chemical irritation and the nerve simply just doesn't like to be on tension. Okay, it's just irritated and it doesn't like the extra tension going across it. However, we do see if there's a severe enough injury going into the spinal cord that people will often have severe neural tension changes in both lower extremities. And when we go to test it, we have to be careful in those instances, or rather just be careful all the time in case this is the situation. We will see almost a systemic type reaction to it. I had a patient at the beginning of the year who had trauma to the axial skeleton. And when testing a slump test, even though being very careful with it, very slow, he actually almost passed out afterwards as he has like a vasovagal response. We got him down on the table. I thought that might happen as he was telling me his symptoms, but just wanted to see if if that was something I needed to address with him at the beginning of his evaluation. The idea behind disc bulge neural container theory is that as we move through the motion, meaning if we go into ankle dorsiflexion, we're going to be pulling the tibial nerve, right, and which is going to be a portion of the sciatic nerve, down and creating tension through the cord, through the tibial nerve and the sciatic nerve, going down until it becomes the plantar nerve in the bottom of the foot. So as we go to raise this individual's foot up, what's going to happen is they should have less sensation once we get to the verge of tension when we go to plantar flex their ankle. Okay, so once we plantar flex it, and if they have less tension, that's theoretically is because we just took less tension off the dura and the whole nervous system. If we keep them in a position of aggravation within ankle dorsiflexion, knee extension, hip flexion to the point of discomfort, and if we had them knock back their head into some cervical extension, theoretically we put some slack on the system, and that should alleviate some of the discomfort and tension that they're feeling. Now, just because they have tension, right, doesn't mean that that's a positive, and or if they have a reproduction of symptoms, that doesn't for sure mean they have a disc bulge or anything. The only thing that we do know for certain when someone goes to have a range of motion testing and a slump test is whether or not they are sensitive to that position. That's pretty much all we really know for that matter, because we can't see how we're getting them there. So when we go to move them up into knee extension and ankle dorsiflexion, what we're really looking for is there a difference from one side versus the other. So that's why we want to check their unaffected side first, and then if we find that no issues there, then what we do is we go and compare it to the other side. And as they go to move through the motion, or as we move them through the motion, what we're looking for is, does it stop early or does it reproduce their symptoms? Okay. Even if we bring them up to a point and they don't have their back pain or their hip pain or whatever it is they're coming in with, as we get them to the point where the tension begins, that doesn't mean it's a negative, especially if one side stops much earlier than the other side. In that case, we need to record that, and that's going to be a test that we can use to show the patient that the interventions that they're doing are helping that tension sensitivity improve. Okay. So the second theory that we're going to go over is the respiratory or movement variability of another possible reason why we see what we see when we have someone go through a slump test. That's the official name of it now, so we're going to go with it. So I brought a few models so we can take a look at this. So when someone goes to move into ankle dorsiflexion, all right, what happened is it's not a straight kind of up and down sagittal plane movement like this, but rather what happens is we see there's a little bit more of eversion, okay? So as we come up, it's going to be eversion this way. So with ankle dorsiflexion, so as we're doing the slump test, as we go to grab the person's ankle and we bring it up, what's going to happen is we're going to end up creating more tibial internal rotation, okay? So this is the fibula here. We're going to create more internal rotation as we go into ankle dorsiflexion, okay? So with more ankle dorsiflexion and more eversion, that'll give us more tibial internal rotation. And if we go up to the knee, because of the screw home mechanism of the knee, meaning in the last 20 to 30 degrees of knee extension, we're going to require more tibial external rotation. Okay? But we have a tibia and a foot that we're trying to remain straight up towards the ceiling as we do the slump test. So since we're not letting the foot or the leg roll out as we do the test, increased tibial external rotation is the same thing as tibial internal rotation, okay? So tibial external rotation is the same thing as if we fixed the tibia and we internally rotated the femur. That's what I meant to say, in case I didn't say that. So now we have a tibial increased internal rotation because we have ankle dorsiflexion, which gives us more eversion, okay? And then what's also going to occur is we're going to get more tibial external rotation, but because we're not allowing their foot to move as we do the slump test, we're going to drive more femoral internal rotation. Okay, so we got more tibial internal rotation and then quite a bit more femoral internal rotation. And then as we keep going up, as we get to, say, the SI joint, if we were to keep moving them up into that position, what will happen is as they come up, we're going to create more internal rotation. And as we get more internal rotation, we're going to get this occurring. So it's going to be internal rotation. We're going to drive this action right there. Okay? Which is going to create more nutation on that side. Okay? So let's say someone doesn't have very much femoral internal rotation, or they don't have very much sacral nutation on that side, or they're sensitive to it. As we go to bring someone up into that position, and let's say they're in a situation where they're either they're already kind of in this because we're forcing them to be in that slumped position, and we're not allowed, and their body isn't being allowed to like kind of shape change very well, or maybe they're lacking the ability to do it. As we go to bring their leg up and they need internal rotation, okay, if they can't get this, they're going to feel something that feels tight, okay? So even though we're creating more ankle plantar flexion at the top to see if that alleviates their symptoms, we very well could be creating more femoral external rotation as we go to create more ankle plantar flexion, right? Because we don't require quite as much as much femoral internal rotation and tibial internal rotation as we go to plantar flex the foot. So if we bring them up just to the point when they start to feel their symptoms, and then we plantar flex them, and they were sensitive to being in this position, and we go to plantar flex the foot, we very well could get this right here. Now if we kept going up all the way up to the skull, so what will happen is when we go to bring the head down, we have lower cervical flexion, and then we also have upper cervical flexion. So what will happen though is upper cervical extension is more closely linked with more femoral external rotation, and I'll link Zach Cupples' human matrix pre-course to this, so you can review some of that material. But we'll be going over those concepts later. What will happen is if we're lacking upper cervical motion, we'll see that as the person comes down, they'll already be using a strategy where they can't let the back of their hip muscles or their lower back relax. So as they go to bring their leg up, if they don't have enough range of motion here, they're going to automatically start to create a compressive strategy on the back side of the hip here. So what that does is they go to lift up, they won't have enough expansive or eccentric orientation through here, and they're going to feel pulled down the back of the leg or in the hip or something along those lines. Okay? Regardless of the theory that we're looking at, depending on their level of sensitivity, the treatment suggestions will be the same. If someone can't, for the most part, stand up and keep their knee straight and touch their toes without some sort of compensation, or they can't do a straight leg raise to about 90 degrees of hip flexion, if they can't do either of those two things, there's a pretty good chance they shouldn't be sitting in an office chair or some other piece of furniture where they're putting their feet up in front of them. Because if they're putting their feet up in front of them, they're biasing themselves to a position in which they can't access yet. And if we take any joint or any nerve and we were to put it at its end range position 10, 20, 30 minutes, an hour, 2 hours, and we keep it there, the cells locally just do not like it. I'll link an article talking about how cells they're talking about in yeast cells. yeast cells, and how the cellular productivity actually decreases when it's under compression. But it very quickly will start to recover and get back up to its usual efficiency once the compression is alleviated. So with that said, usually what we like to do is people sit in positions or spend a lot of time stretching, but they're not going after the mechanics in the pelvis that we're just going over in terms of their ability to counter-nutate and nutate, right? If they haven't been able to improve those, just stretching structures is usually not going to feel good at a cellular level, okay? Yeah, so that's what we got. Let me know if you got any questions, or if I created more questions, please feel free to reach out, and we'll talk about it. All right, stay safe.